we're going to start with just a quick introduction and welcome, and then I will spend some time going through our updated slide set. So you might have seen the old, it doesn't feel that old, but the sort of original direct contracting slide set from our January PNHP activist call. So we've updated that. We've added some new information about REACH and a few other, kind of spiced it up a little bit based on feedback that we've gotten from actually doing these talks. After that, we're going to let you ask some questions of our gurus, Dr. Weisbart and Malinow. And then the last section of our workshop will be, we're going to break out into small groups and practice answering some questions, some sample questions that you might get from the audience. And we'll do that in small groups together. So, you'll be among friends. You can kind of practice how you want to answer things. And know that the breakout sessions will not be recorded. So you can feel free to say whatever you want. This session will be recorded for folks who weren't able to make it tonight. And then after that, we'll gather back and see how we did and say goodnight. And like I said, if we get out before 90 minutes, then you get that time back. So why don't we get started? It's 7:03. Looks like we've got just about everybody who RSVP'd is here. So that's great news. So I'm going to go ahead and start sharing my screen. Just give me a second here. Okay, so there, I'll get into presenter view. All right, so here we are. And now before we get into the updated slide set, the slide set that you will be presenting to your groups, I wanted to spend a few minutes talking about just some tips about giving this presentation and some general tips about taking questions from the audience. So when you're doing this, you may have someone to invite you to speak. They may give you an hour, they may give you 30 minutes, they may give you 5 minutes. And no matter how much time you have, I want you to keep these 3 ingredients in your presentation. No matter how much you have to expand or shrink this, make sure that you educate, you advocate, and you activate. And I'll explain what those 3 things are. So first, educate. This is a very complicated program. And I'm guessing that 98% of your audience, maybe or 99%, maybe 98%, since we've been doing so much work educating, they haven't heard of this program. So you need to explain it in simple and concise terms. And you probably will need to spend the bulk of your time explaining what this is. And next, you want to advocate. Because as we know, the folks who created this program, they frame it with these benign goals that we're reducing costs, we're improving quality. We need to explain why this is actually bad for seniors and for Medicare itself. And then finally, before you let people go, you have to activate them. And I think right now, a lot of us feel like we can't make a difference in the world or, anywhere. So it's our job to challenge the audience, to give them, to get them excited, to give them concrete steps to get involved and let them feel that they can actually make a difference and win. So those 3 things I want to have in your presentation, no matter how short or long it is. Now, before we get to the main attraction, I want to share some basic tips about answering questions. So, most presentations, you provide the information and then you give the audience a chance to ask you questions, and that can be kind of stressful, but it doesn't have to be. So these tips are not comprehensive, but they do provide some strategies that will cover you in most situations. And remember, at the end of this workshop, we're gonna practice answering questions in a small group, so you get a little bit of time to practice among friends. So my first tip is, when possible, and really for all of these questions, you want to try to create a connection with your audience and with the person asking the question. So you want to show that you acknowledge their concerns, don't just dismiss it. And if you can agree on what the problem is, that's even better. So here's an example. So someone says, I heard that REACH will improve health equity in Medicare. Why would you be against that? So let's acknowledge their concerns. So we could say, it sounds like health equity is extremely important to you. And it's important to me too. And I realize this is a lot of words for the screen. which is why I'm extremely concerned that CMS is using the concept of equity as a cover for privatizing Medicare, which could hurt vulnerable seniors even more. REACH would allow middlemen to profit by restricting care without any oversight from Congress. And studies show that the best way to make Medicare work for low-income beneficiaries is by eliminating premiums and copays, expanding benefits to cover all health needs like vision, dental, and hearing. Why don't we try that instead? So the next tip is, you don't be afraid, don't avoid a difficult question, but always make sure you pivot or you bridge back to the thing that you want to say, to one of your key messages. And you always want to maybe keep a short list of what your key messages are. And as a trick, you can use a phrase like, what a lot of people don't realize is, or the most important thing to know about this is, and here's an example of that. Someone asks, why can't we just give these value-based models time to prove their worth? Why do we have to cancel them? Why do you want to cancel this right away? So how do we bridge or pivot back to our message? You could say, well, what a lot of us don't realize today is that Medicare has experimented with value-based or managed care models for decades with disastrous results. From HMOs in the 70s to Medicare Advantage today, these models have never reduced spending or improved patient care ever. Traditional Medicare spends 98 cents of every dollar on care and has consistently outperformed managed care for decades. So based on the evidence, let's build on what we know is proven to work, not destroy it. So we didn't avoid the question, but we definitely pivoted back to what we want to say, that managed care has been a failure, that traditional Medicare is strong, and we need to build on it. Another trick is, when you're not exactly sure what to say, you can always get personal. And a lot of folks on this call are physicians, retired or working or in training, and you probably have a lot of great stories that you can share to explain your points, where you don't need to throw out a bunch of data that you don't understand. And you really shouldn't be afraid to share those to make the point that you want to make. So here's a question. Don't seniors need a third party to help coordinate their care, right? This is a big argument for direct contracting and for REACH. And you could say, hey, I've been a primary care physician for 30 years. It's always been my job to coordinate care. I can give you an example, can I give you an example of what happens when we let middlemen coordinate care? Last year, one of my patients with stage 3 lung cancer needed a specific procedure. The insurance company refused to cover it. We spent weeks and weeks fighting with the insurer. And in the meantime, you could go on and on about what, but I think a lot of you probably have a story like this, an example of why we shouldn't let, third-party profit-seeking middlemen get involved in the care between the patient and provider. That's just an example. And now finally, no one expects you to know everything. If you truly don't know the answer to a question, don't try to make it up. It's not actually a bad problem to have if you don't know the answer, because it's a great excuse to follow up with the person and make an additional connection. So someone says, what is the discount reduction for the 50% risk sharing professional track and REACH? And what is the quality withhold of them? Okay, I'm sure even Liz Fowler doesn't know this off the top of her head. And there's no reason why you would either. So it's okay to say, I'm sorry, I don't have that information in front of me, but I can certainly get it for you in the next couple of days. If you give me your email, I can follow up. So you're making a connection, you're showing that you care, but you don't have to know all the answers. No one's expecting that. So don't even try. Okay, so that was just some little tips and tricks. And now we can get to the heart of the matter, which is the updated slide set, which I'll put in the chat a link to this slide set so you can download it and use it as you want in your speaking engagements. So I'm putting my hat back on as PNHP speaker on direct contracting and REACH. So today I want to talk about two separate but related programs. The first is called Medicare Direct Contracting, but it's also going to be replaced by a similar and even more dangerous program called REACH. Both of these programs pose a major threat to seniors and to the future of traditional Medicare. And in this presentation, I'll explain why direct contracting and REACH are so dangerous, why they must be stopped, and what you and I can do to stop them. How does that sound? Good? Okay. So first, let me explain a little bit more. I know it's confusing to talk about two programs at once. So I'll give you a quick history of direct contracting and REACH and why I'm talking about two programs at the same time. So you'll see in 2019 and 2020, Medicare Direct Contracting was developed in the Trump administration. It was launched in April of 2021, so less than a year ago. Me and folks like us have been campaigning to stop Medicare Direct Contracting for the past few months. And then just recently in February, Medicare announced that it was terminating direct contracting, and it was announcing the development of a new program called REACH. And REACH is supposed to begin January of 2023. So that's why I'm talking about direct contracting. It's happening now. It will be replaced by REACH this coming January, so a little less than a year from now. That's the timeline. So now that you kind of know generally what we're talking about, let me explain how direct contracting works. Because like I said, REACH is basically a carbon copy of direct contracting. And if you hear me use the names interchangeably, that's why. So direct contracting is a pilot program that was launched late in the Trump administration as a way to change the way that Medicare pays for seniors' care. Instead of paying doctors and hospitals directly, Medicare gives third-party middlemen called direct contracting entities, or DCEs, a monthly payment to manage seniors' care, which allows them to keep as overhead and profit what they don't spend on medical services. That's the basic framework. So traditional Medicare, this is the starting point. This is where this program is happening. Traditional Medicare, Medicare pays providers directly for patient care. It's pretty straightforward, pretty transparent. Now in direct contracting and REACH, Medicare is paying a middleman a set amount each month to manage patients' care. And I'll say manage in quotes because we're not exactly sure what that means. So these companies, they're a middleman in two ways. They're both a middleman between Medicare and the provider and a middleman between you and your provider. And before we go on with the details, I just want to see, has anyone here ever heard of direct contracting before? Anyone raise your hand? Okay. Well, you can't raise your hand, that's cheating. So if you haven't heard of direct contracting, it's not because you're not paying attention, you're in good company. Because until recently, most Medicare beneficiaries and even most members of Congress had never heard of direct contracting. So that begs the question, how could such a radical change to traditional Medicare happen under the radar? Well, the answer is that it was developed by an obscure agency called the Center for Medicare and Medicaid Innovation, which you've probably never heard of either. So let's take a moment just to see what we're talking about. So as I said, direct contracting is born out of CMMI. And this is an obscure agency that has the power to implement pilot programs and scale them up to all of Medicare without congressional approval. Now, where does CMMI fit into our National Healthcare Administration? So this is a chart of Health and Human Services, and that's the agency that's responsible for most of our healthcare system to the extent that we have one. So, the FDA, CDC, all these agencies that you've probably heard of a lot recently. The head of HHS is Javier Becerra, and he is appointed directly by President Biden. So he reports directly to Biden. The president is his boss. Now, Medicare, which is what we're talking about, is run by another agency within HHS called CMS, the Centers for Medicaid and Medicare and Medicaid Services. They kind of drop the middle M there. That's an agency within HHS. So now we're going to look at CMS. If you put on your reading glasses and look really closely, you can see that CMMI is an agency within CMS, there it is, and it's run by a person called Liz Fowler. She's the director. Now, again, this is a pretty tiny agency, but it has a lot of power. So they're actually very important. It's important to remember that everything this agency does, they can scale it up to all of Medicare without a yes or no from Congress. So now that we know a little bit about this agency called CMMI, let's let's look at who was in charge of CMMI when direct contracting was first developed, because there's a very interesting backstory here. So this fellow here is named Adam Baylor, and he was a former roommate of President Trump's son-in-law, Jared Kushner, who you've probably heard of, and he ran CMMI when direct contracting was first proposed in 2019. But before he was at CMMI, Baylor ran a startup called Landmark Health. Now, Landmark Health later became one of the first companies to win a contract with Medicare to be a direct contracting entity. Not good. So if you thought that was a fun story, we can do it again. So after Adam Baylor left CMMI, he was replaced by a young man named Brad Smith. And before Brad worked for CMMI, he previously worked for the commercial insurer Anthem. And have any of you heard of Anthem before? Probably, yeah. They're very, they're a big commercial insurer. They're very active in Medicare Advantage. And so then he used to work for Anthem. And then Anthem became a direct contracting entity through its CareMore subsidiary. Now, this fellow, Brad Smith, he's no longer with CMMI. He now runs an investment firm called Russell Street Investors, where his team actually includes a group of other CMMI alums. So there's a lot of revolving doors going on here. So there's two examples of how this revolving door has really been a gift to these industries, to these DCEs. So if this all seems pretty fishy to you, it's because it truly is. And HHS's own watchdog was shocked to see that the draft program proposal actually listed some of these companies by name and said it raised very serious ethical concerns that the program was established specifically to benefit these companies, several of whom won contracts to be DCEs. So the Office of General Counsel warned, but the agency didn't do anything about it. This is the program that we're basically stuck with. So now that we've kind of peeked under the hood at the agency that brought this program, let's look more closely at what the DCEs are. Who are the people running the actual direct contracting entities? So right now, there are 99 DCEs currently running. They're in almost every state in the US. They just released kind of a new batch of DCEs, so we haven't mapped out exactly where they are, but it looks like they're in pretty much every state. And virtually any type of company can apply to be a DCE or reach middleman. It includes commercial investors, as we saw, Anthem, a lot of private equity investors, Wall Street investors. And importantly, applicants are approved without any input from Congress. So it's CMMI that is approving these contracts, investigating the owners. And then if you look at, here's one example of just one DCE that's currently operating. Its name is ILUMED, and they do not capitalize their name for some reason. And as you can see here, this is their management team, their leadership team, and only one member of the team is an actual medical provider, has any kind of medical experience. And this woman circled here is a registered nurse. It doesn't seem like she's practicing now. And if you dig a little deeper, you go on the news page of their website, it gives you a good flavor of what their business is about. So the two main news articles here. So they most recently hired a chief medical officer that they recruited from insurance giant Humana, which you've probably heard that name. They're also very active in Medicare Advantage. So that kind of gives you a sense of where he's at. And then just as important, or maybe more important, is this news that they pulled in $16.5 million from investors. So as you can see, Wall Street investors are really interested in putting their money into these companies. So it makes you wonder, why is Wall Street so interested in a company that claims that it's going to be saving money for Medicare and improving quality for patients? Where is the money in that? And if you step back and look at this model, you see, we went from traditional Medicare, where Medicare's paying providers directly, to direct contracting. We're paying the middleman to pay providers. But there's another set of players that we haven't really talked about, which are the Wall Street investors who are backing the DC and REACH middlemen. And they're really just flooding these companies with new money. So again, how do companies who claim they're going to save money, how are they going to keep these investors happy? Obviously the investors are expecting to make a profit. So here's a breakdown of the business model for direct contracting and REACH. It's a three-pronged business strategy, which is similar to most businesses. They need to maximize the revenue from Medicare. They need to minimize the revenue that they're spending. This would be on patient care. And finally, they need to increase their volume through enrollment, because they're not going to make a lot of money with just 10 enrollees. They need thousands and thousands for this business plan to work. And we talk about maximizing revenue. It's a little bit complicated, but I think it's important for you to understand what this means in terms of managed care. So they do this little trick that's been going on in Medicare Advantage for quite some time, where they do this thing called upcoding. They make seniors look sicker than they really are. And the reason is because REACH entities and direct contracting entities are paid a monthly flat fee from Medicare per enrollee. But the sicker the patient looks, the more money they get from Medicare. And this has nothing to do with the amount of care that beneficiaries receive. It's only based on these diagnoses. It's a little confusing. So here's a visual example. So here's a chart of a 76-year-old female patient with some pretty common diagnoses. Now, each condition gets a score, and you add up those scores, and that tells you how much money Medicare will pay the REACH or the direct contracting middleman when you add that up. So in this example, the REACH DC middleman will get $9,000 per year based on this potential health needs, we'll say. Now, here's an example of that same person, 76-year-old female, when there's upcoding involved. So you see here, obesity becomes morbid obesity, and that's got higher points. Diabetes now includes retinopathy, asthma is COPD, and so on and so on. Everything in red is where they've upcoded. Again, same patient, nothing's different, just the way that they track and record these diagnoses. So now if you add all that up, Medicare's paying this particular middleman $32,000, so more than triple what they were paying before. And this again is just not based on healthcare, not based on services provided, just based on record keeping. So it is really, they're really maximizing the revenues in that situation. And we do expect to see that in this program. So their next strategy, now that they've gotten all this money from Medicare, how do they keep more of it for themselves? And it's important to know that within traditional Medicare, there's not really an incentive for anyone to restrict care. But when you introduce these middlemen who are allowed to keep as profit and overhead what they don't spend on medical services, now you've got the incentive to ration and restrict care, because they get a flat fee and they're allowed to keep what they don't spend on care. It's a complete change from traditional Medicare. So again, these incentives do not exist in traditional Medicare. This is probably the biggest single change that we've seen. And then finally, they got money coming in, they're keeping money from going out. How do they amplify it? How do they make it bigger? So if you're on, you look at most healthcare middlemen, commercial insurers like Humana or Aetna, they have to convince patients to enroll. Thus their massive marketing campaigns. And I'm looking at this guy, Joe Namath. If you turn your TV on anytime between September and December, you're going to see this guy 24 hours a day, right? Because they have to convince people to join up. But in direct contracting and in REACH, they don't have to do anything, because Medicare, CMS automatically does it for them. And this is how it works. So Medicare will automatically search seniors, 2 years of seniors' claims information, claims history. And if they find a primary care physician that you've been seeing that is linked to a direct contracting or REACH middleman, they will automatically enroll without your consent. they call it aligning. They automatically align. So if a senior's primary care physician, even if they've seen multiple physicians, if their main primary care physician is affiliated with a REACH or direct contracting middleman, Medicare will automatically align them without the senior's consent. And again, this is nothing that we've ever seen in traditional Medicare before. And it's all done under the radar, behind your back. So if you are aligned, you may get a form in the mail, or you may get an email that looks something like this. This is an actual letter that someone sent us. And if you're like me, you're going to see that no action needed, and it's going to go straight into the recycling bin, right? Because most of us, when they see a long letter and it has something to do with insurance or something to do with healthcare and it says no action needed, it goes straight into the trash. So what can a senior do if they're aligned to the DCE without their consent and they don't want to be? Unfortunately, the only way to get out is to change primary care physicians. And CMS told us this themselves. This is the only way to get away from these middlemen. And that's tough for anyone, but if you think about those with complex health needs or those who live in rural or other underserved areas, it's virtually impossible. And we feel that asking seniors to change their primary care physician undermines traditional Medicare's promise of a free choice in provider. So again, a very radical change to traditional Medicare. I know that we've talked about kind of the dangers to individual seniors and adults with disabilities who are enrolled without their consent. I want to take a minute to talk about the future of Medicare itself, which should be a concern for everyone, because eventually we're all going to need it. And when I say that DC and REACH threatens Medicare solvency, it's a fancy way of saying it could bankrupt Medicare, because we're looking at traditional Medicare is very efficient, spends 98% of its budget on care, but DC and REACH, they're allowed to spend as little as 60% of what Medicare pays them on patient care, keeping the other 40% on overhead and profit, a huge change from traditional Medicare. And this is what that looks like. So you see traditional Medicare, 98%, 2%, that's pretty good. Even Medicare Advantage, it's not great, but they are required to spend 85% of their revenues on patient care and keep 15% as overhead and profit, which they usually do. Now, there's no such rule for REACH and direct contracting middlemen. There's a pretty complicated what they call risk corridor, but basically they're allowed to keep 40% of what Medicare pays them as overhead and profit. And it's kind of an eye-popping amount, especially when you compare it to traditional Medicare that works pretty well. Now, again, if you're worried about this expanding to all of Medicare, this is absolutely CMMI's goal. And they've been saying this for the past 6 months or so, that their goal is to move all Medicare fee-for-service, which is what traditional Medicare is, beneficiaries into these accountable care model. So moving them into REACH or something very much like it by 2030. That's 8 years from now. They want all of this to move up to all of traditional Medicare. So this is happening very, very quickly, which is why we need to get busy stopping it. So where do we go from here? I told you a lot of kind of scary information, but the good news is that we're building a grassroots movement to stop direct contracting and to stop REACH. So I want to tell you a little bit about what we've done so far and where we're at in this campaign. So just this past fall, this has all happened pretty quickly, a group of physicians pictured here, they delivered a petition to Secretary Becerra and met with a lot of members of Congress to educate them about what was going on. In January, more than 50 members of Congress sent a letter to Secretary Becerra demanding an end to direct contracting. It got a lot of attention. And then just about a month ago, Senator Elizabeth Warren spoke out about direct contracting in a Senate hearing, which also got a lot of attention. And those are all kind of big, important people. But in the meantime, we've had thousands and thousands and thousands of grassroots activists, like folks like you, who've called HHS, who've called their members of Congress, who've written letters and op-eds, have gotten tons of media attention, made lots of good trouble, and really put the pressure on HHS and CMS to end this terrible program. So there's been a lot of activity. And basically, through all this activity, we've made direct contracting a bad name. It's a toxic name now. CMS knew that it had to respond. So on February 24th, the agency announced that it was, in fact, going to cancel Medicare Direct Contracting. But there's a twist. They wanted to replace it with a virtually identical program called ACO REACH. And I like this headline because it's basically what they did. They gave it a makeover. They put some lipstick on it, but it's basically the same program. And I think this Wall Street investment analyst, his name is Spencer Perlman, he said it best. This is from a report that came out the day after CMS made their announcement about replacing direct contracting with REACH. He said, the reforms are one part public relations exercise and one part modest revisions that should not tangibly impact the for-profit entities currently participating in the model. So the industry was not worried. They were worried for a little while, but when they saw what the REACH program was, they were not worried at all. So let's talk about what are some of the things that are still in the REACH program. What's basically everything that I've talked to you about today. There's still a middleman between Medicare and providers. They can maximize revenues by upcoding. They still have that profit incentive to restrict care. They can keep 40% into their pockets. They automatically enroll seniors, and anyone can apply, including private equity investors and commercial insurers. So we fully expect everything that we didn't like about direct contracting to be in REACH. So in some ways, it's actually worse. When you read the fine print, we saw that there were some big giveaways to the industry. They lowered, I don't want to go into the details of this, but they basically lowered the penalties for the middlemen failing to control costs. They lowered the penalties for failing to improve quality or maintain quality. And they said that any middleman who's currently in direct contracting can just roll into the REACH program. They don't actually have to reapply. So all of the folks that we see that we've met so far in this presentation, they can all just roll right into it without that much problem. Now, when CMS made kind of a big deal about focusing on equity, which is something is probably important to everyone in this room. It's important to me. But when we looked into some of these equity incentives, we realized that they're either meaningless or they're encouraging profiteering in underserved communities. And that's a big red flag for all of us. How are they doing that? So first, Medicare is providing the middlemen with a financial bonus simply for reporting demographic data like race and income. Now they're not using that data to hold them accountable to any type of outcomes. It's just you report the data, we'll give you extra money. Next, they're going to pay the REACH middlemen $360 per year simply for enrolling underserved beneficiaries. And again, this does not matter how much care that they provide, simply for enrolling them. And they're going to do something that's a little complicated. They're going to allow the REACH middlemen to use demographic factors to increase the risk scores. So we talked about using people's, inflating health diagnoses to increase those risk scores to get more money from Medicare, that upcoding. Now they're actually letting the middlemen in REACH not just use health diagnoses, but to use demographic diagnoses like income to say, now I need more money from Medicare because I'm treating someone who's low income. Again, they're not providing additional care, they're just getting more money. And then CMS said, well, we're going to make these middlemen fill out an equity plan. And okay, that sounds pretty good, right? An equity plan. This one was kind of a shock to me when I looked at it. They said, okay, you have to fill out an equity plan, but we're going to give you a template, a worksheet basically that you can fill out. And this is what it looks like. I can actually put a link in the chat of this so you can look at it yourself. But this is the so-called here's the link in the chat. This is the worksheet that they have to fill out. There's a couple more pages to this, but this kind of gives you a sense. And I think, this looks like something my 5th grader would do in social studies homework. It's very simple. It doesn't seem like this is if someone's trying to be serious about improving health equity, they would do something a little bit more serious than this. All right, so how do we stop REACH? Now we've kind of ended up with this program that's in some ways even worse than Medicare Direct Contracting. How do we solve it? How do we stop it? And we know that Wall Street's not going to give up this cash cow without a fight. So we do need everyone who cares about seniors, who cares about those with disabilities, and cares about the future of Medicare to get involved. We do know that the agencies will respond to pressure because they did something, it just wasn't good enough. So how can people get involved? For individuals, the best thing you can do is sign and share our petition. We've got thousands of people on it, but we need to get a whole lot more. We need to keep that pressure up. And for those in the speakers training, I should say we're working on kind of rebranding our materials. So this will probably change, and I'll update that. You can write a letter to the editor in your local news outlet, and we've got some great talking points and guidelines. And if you're an organization, you can sign on to our organizational letter against REACH and Medicare privatization. And for organizations, you can share the petition with your own members, because again, we need to get thousands and thousands and thousands of people on this list. And that's it for now. We've got a lot of, we're gonna fight over the next few months. We've got a lot of activities coming up, a lot of activities planned, and we're gonna need everyone to get involved. So if you sign the petition, we'll have your email. You can give me your email, and we'll keep you updated on everything that's going on in our fight to stop direct contracting, REACH, and Medicare privatization. So I am going to get out of my screen share. Okay, and we're back. So we are just a few minutes behind schedule. So I wanted to take a few minutes now to introduce the next part of our program, which is a question and answer session with our two, we call them our gurus, Dr. Ed Weisbart and Dr. Anna Malinow. If you guys don't mind unmuting yourself. All right. So I wanted to take a little bit of time to let folks in the room ask questions about the program, ask questions about the slide set, anything that you feel that you don't understand or that you would like to know to be more prepared to speak to your communities about this. So I will try to call on you. I see a hand from George. You want to go ahead, George?
Yeah, thanks very much. Claire, I got a million questions, but most prominently, if this is such an evil program from the Trump administration, then when Becerra, who's a Medicare for All supporter, and Fowler came in, I can see that they maybe have had to continue the program that already had existing contracts. But why in God's name are they not stopping it at the end of this year? What's motivating good progressive Democratic administration?
Get over yourself.
Okay.
Thank you, George. From stopping this, yeah.
Yeah, that's a great question. Do you want to, Ed or Anna, do you want to jump in?
Well, I guess I can. I think that it assumes that our Democratic administration that we have right now is progressive, right? And if you think that it's progressive, then it's a little bit of a surprise. But if you don't really think that it's very progressive, then it's not that big of a surprise. I happen to think that that President Biden appointed Liz Fowler, knowing full well her history. Her history is talking, this revolving door between corporate, and she helped the Bush administration with the 2003 Medicare Modernization Act. She also helped pen the ACA, and now she's back at the CMMI, which she helped write, right? Because the CMMI was authorized by the ACA to further privatize Medicare. So I wish I could say that it's a surprise. I wish I could say that President Biden would stop it, but it's really no surprise that they're not, sadly.
Okay. How about Cheryl? Cheryl Kunis, do you want to ask your question?
Yeah, I read somewhere where there was going to be some further oversight on upcoding so that they wouldn't be able to do upcoding to the extent that they have done in Medicare Advantage. That's one question. And I also think that we seem to, in your slides, in your presentation, which of course was fabulous. I found all of your discussions in the past incredibly useful and so clear. But we keep talking about seniors and Medicare and, just that Medicare and seniors, but it really affects everybody, not just because people are going to get older and become seniors, but as Medicare's money is used up by all these private investment firms, everybody's going to pay more taxes. And, they're already talking about a new Medicare tax, so that it really affects everybody. And people unfortunately do respond to money. So even young people are going to be hit with greater taxation because of the fact that this organization is making so much profit. So I'm just wondering if that's something that should kind of be added into it as well. And in terms of stopping it, I think everybody knows that one of the DCEs was stopped by the Biden administration with the development of REACH, which was the geographic one. So that, obviously he was aware of it and stopped that one. I just have one other thing is the first paragraph of the letter that goes out to people seems to me that it's outright dishonest, because it says, any doctor who takes Medicare you can go to, but you can only go to the doctors who are part of that REACH, who are part of REACH. Isn't that correct? Once the patient is in REACH because of their PCP. And there were a couple of other things. They said your Medicare will not change, but it will change, for all of the reasons that we just talked about. So I'm just wondering how they can send that letter out if just the first paragraph that I read had like 3 total inaccuracies and dishonesties in it.
So if I could jump in, great questions, Cheryl. I'm glad you asked this. And I want to take the last part that you brought up first, if I could. It is actually, that letter is actually accurate. That's one of the things that makes our discussion more complicated, because it is actually true that if you're assigned to a DCE or to a REACH entity, you do retain the ability to go to a non-REACH, non-DCE physician or hospital. So that's one of the key ways that this is different from Medicare Advantage. Medicare Advantage can set their narrow network, and then if you go outside, you may not have any coverage, or at least partial coverage. That concept of being compelled to stay within the network is not true in REACH. That's one of the ways it's perhaps better, you could say, than Medicare Advantage. However, you've got to look at how the money flows and who the people are that are making money, and they want you to stay in the network. And they have all the sophisticated tools to know how to get you to do that. So they're going to do everything they can. And most people, when you have something important going on, something major in your health going on, the first place you go to figure out how do I get this treated is probably the person who diagnosed you, who you have a relationship with, your primary care doctor. And your primary care doctor under traditional Medicare has no mixed allegiance. But under this program, under REACH, primary care docs who have high leakage outside of the network are probably going to get penalized by the REACH organization. So you can no longer trust their guidance as plainly as you could before. Most doctors are obviously highly ethical, trying to do the best they can, but you can go outside, but you won't have the same ease at doing that. And what I'm frankly most frightened about is that the people that are in traditional Medicare will be assigned to a REACH. The REACH program may do something to mitigate your copays or deductibles within REACH, and then you'll drop your Medigap policy. And then when you can't afford to go outside of the REACH entity, that's when they'll really be able to compel you with that. The upcoding question you brought up is also what you said is true, that they have changed the methodology for calculating benchmarks. So it's arcane. We think that the dramatic impact of upcoding is still going to be there, just maybe not quite as dramatic as it is under Medicare Advantage. So it'll be less, but it's arcane and complicated and still very real as a strategy to make money for these plans.
Are there specific rules of things they can't do in terms of upcoding?
I can't answer that. I don't have it. I don't know, Anna, if you have a better answer, but
No, whatever it is, they're going to get around, to be honest with you, because they have really excellent actuaries. So it doesn't really even matter what the rules are.
Mhm.
Yeah. Okay, let's thank you, Cheryl. Let's move on to another question. So I want to get to as many people as possible. Jay, I saw your hand up, Jay Brock.
Sure, thank you very much. Either person can answer this, hopefully. How are these organizations supposed to actually save Medicare money? Thanks.
Well, that's a really great question. They're not going to. I think that's really the bottom line is they're not going to. It's sort of the same idea with Medicare Advantage, that they were supposed to save Medicare money. And we know that, in fact, they cost Medicare billions and billions more than traditional Medicare. So no, they're not going to save money. And that's why they have so many investors, and why Wall Street is so very interested in these. Otherwise, there would be no interest. I don't know, Ed, if you wanted to expand upon that.
Just that that's the absurdity of this model, that, you know, if you ask the ACO industry itself, which is sort of the forebearer of the REACH program, if you ask them, they brag about saving what they claim is 1 or 2% on the cost of healthcare in the United States. I don't think that's the case at all. I think they add the cost, but even if you take them at their word that they're going to save 1 or 2%, we all know in PNHP that we're already spending double every other country. So somebody claiming to save 1 or 2% is just, you're just irrelevant. I mean, you know, it's ridiculous to make that assumption.
Okay, that's a great question. Let's move on. Corinne, do you want to jump in?
I have a couple of questions. How did Medicare let this happen? And how do they convince doctors? I've heard, but I want to hear what you say. How do they convince doctors to sign up?
The answer is negative 8,809.
What is that? I don't know. Anyway, how do they convince my doctor to sign up? And since I tend to work with a lot of convince doctors about different things, how am I going to convince physicians this is going to really hurt them in the end?
Okay, I'll take a stab at it. So 2 great questions, Corinne. How did Medicare let this happen? Well, the way that these models are proposed is not really Medicare. It's really under the CMMI, which Claire told us is in this obscure agency that is under CMS, it's under HHS. And this agency was created by the ACA in 2010 with the mission to create these models to control costs and improve care, or at least not worsen care. And then they were given broad authority to scale up any of these models to all of Medicare without congressional approval. So it's not really why did Medicare let this happen? It's that the ACA let it happen. And Congress voted for that. So that's how we got this. I don't know if that answers the question. And then how are doctors how are they being convinced to sign up? Well, I think that they're being given promises of better pay, of more time with their patients, of less paperwork. I mean, it all sounds great. Honestly, I would sign up for a DCE if that's what I was being told, right? So those are the promises. But then, of course, when the rubber hits the road, what's going to happen? The other thing is, as we know, physicians themselves are not making these kind of decisions anymore. Most physicians work for very, very large groups, or they work for health systems, and it's really their leadership that is making the decision, and it's not physicians themselves that are making these decisions any longer.
Another argument with physicians would be to those doctors who understand the difference between Medicare and Medicare Advantage, and not everybody does, but those who do might understand this piece of it. So if you have one visit with a patient who's a Medicare patient today, you collect 80% of the payment from Medicare and 20% from Medigap policy if they have it. Under the DCE, under the REACH model, they'll still have to get that 20% from Medigap if they have it, but now Medicare will pay the 80% minus percentage that they're going to give to the DCE, and then the DCE will pay some of what they collected from Medicare on your behalf to you. So now you'll have 3 different revenue streams that you'll have to track. That you have to track the Medigap plan, you have to track the traditional Medicare plan, and you have to track your DCE. 3 different revenue streams for a single office visit. So your life has just gotten way more complicated with way more overhead to do that, even if they do pay you a bit more.
Right. And then the chance that you might not get reimbursed too is always there.
Okay, let's, I think we have time for one more, and I apologize. We know we have a lot of questions here. Dr. Khan, did I see your hand up?
Yeah, thank you, Claire. Actually, Corinne started to ask the question I was going to ask, but I still don't think I understand the answer. Is there anything that compels either private physicians or institutional employers of physicians to sign up with this plan? Why aren't they automatically outraged? And isn't it our duty in PNHP to be talking to the physicians and the physicians managers who run them to say, this is our posture? I mean, I do speak to people in the community from time to time, but I feel like my main obligation is to talk to the interns, the trainees, and the hospital grand rounds when they continue to invite me back. Why aren't we going to those as our PNHP audience?
Oh, we are, along with these other, I mean, tonight's presentation was focused on the group that it was focused on, but we are having these conversations with those other audiences too. They're getting lured in by the promise of more money, but that was the same promise that managed care offered them too. I mean, it's never, once they get you in, then they can change the thing.
I don't see where they're even promising more money. They're just promising the insertion of a middle person.
I'll give you an example. Clover specifically tells people in their system that if you just simply put the Clover tool, it's a DCE, if you simply put Clover's tool on your electronic medical record desktop, and it automatically integrates with every one of your visits, just use the tool. We don't care what you change. Just put this tool on your desktop, and Clover promises $30 more per visit.
And the really insidious part of that is that you don't even need to belong to the Clover DCE. You can just, download their app and put it on, whatever dashboard it is, and then you'll get $30. So, and that's how they get you, right?
What does that app do? Upcode? What does the app do?
It really makes sure that you optimize, to use their words, your coding.
Oh, how does it help? Shouldn't they be telling me that it will help your patient?
Oh, they have a whole bunch of fancy language around it. Oh yeah, there's 25 other things they claim that it does, but we all know that that's, I don't know any practicing physician who thinks that's true.
Yeah, right. Okay, thanks.
Thank you, Doctor. We could squeeze one more in. Teresa, you've had your hand up. Do you want to jump in with your question before we break?
Yeah, well, Cheryl already hit on it. I think a key thing to this is Medicare is not just something that the government pays for. It's tax money. And I think that should be part of the messaging here, because it's not just, we're all paying for it. And I think that would hit people more if they know that their money is being, the economics of this to me is mind-boggling, that people can't understand the waste and how our elected officials don't see it. And because it makes so much sense the way you frame it, and they all should have to watch this program. But that was just my comment, is that the tax thing should be a major part of it. So.
Yeah.
Well, yeah, there's nothing to add to that. You're absolutely right. Unfortunately, Congress doesn't always listen to facts and reason. They have to worry about their campaign financing as well.
Okay. And Ed, do you have anything else to add before we move on?
Just to add to what Anna just said, sometimes they care about campaign finance because they care about elected votes. And there have been many political candidates who are less funded who won, and higher funding who lost. So what they really care about are the votes, which is why we're doing this session tonight. and why we need to all go out and tell others about it so that we can get up an even stronger grassroots movement.
Right, and something that we said in the last time we did this was the reason that we're talking to seniors is because there's nothing politician fears more than a bunch of angry seniors. So that is our job. Well, it's almost 8, so why don't we move on to the last part of the workshop. I apologize for those who still had their hands up, and you can feel free to put your question in the chat, and if we have time, maybe at the end we can get to it, but I want to make sure we have time for our small groups. So this next part, we're going to break up into small rooms, and there'll be, I think, about 5 of us in a room, and each room will have a facilitator, a staff member, or Ed or Anna. And we're going to answer some questions that I prepared. And like I said, we're all friends here. So if you're not sure you're struggling, we can help each other out. We'll take turns answering questions, and then we'll meet back here at 8:15. So it'll be a little more than 15 minutes we can spend in the rooms, and then we'll meet back here and get some feedback, and then we'll send you on your way. So I know Matt Petty is going to magically whisk us all the way to a small group, a breakout room. You all survived going through the portal. Great. Okay, well, I just want to see if anybody, we just have a few more minutes, if anybody wanted to share anything they struggled with, any advice they wanted to give, any highlights. Claire, the other Claire.
I actually found it fun.
Good.
That's just my personality, and challenging me, and it made me really think about things. Everybody had excellent answers from different perspectives for all the questions. And as we did it, I thought this actually might be a good video to have someone asking questions and several different doctors answering it. It might be could be quite instructive and enjoyable to watch, to see how, different doctors answered some of these questions and approached it.
Yeah, and I think that there's no, one answer to any of these questions. A lot of it is really based on your experience and the points that you want to pivot back to. So it's interesting to see everybody has a different style, and I think that's okay. Mark Newman, you want to jump in?
Sure. So one thing that's continuously confusing to me, and I think, Ed, you went over it very quickly and I couldn't quite get the string on it. How does the money move if somebody is in DCE or REACH and they go to another provider who is not, and so it's charged to Medicare with the Medigap? Now that charge is supposed to go back to the DCE that patient was aligned to. Is there a way that I can understand those motions of the funds?
Well, 2 things. First, the fact that it's this complicated is the problem. So the fact, and you're a smart guy, so the fact that it's this complicated is the problem. But the money, what I was describing was the money within the DCE. If you go to a doctor inside the DCE, then the DCE, your DCE doctor gets paid from the Medigap plan for the 20%, gets paid from Medicare directly, and also but that gets withheld a bit because the DCE, part of the money gets funneled from the DCE, from Medicare to the DCE before it gets to you. So if you're the doctor within the DCE, you have to manage the funding from all 3 of those sources, from the DCE, if you're a doctor that's not in the DCE, then you as a doctor, you have the same relationship you've always had. You've got, if I'm not in a DCE and I see a patient who's not in the DCE, I get paid from Medicare and I get paid from the Medigap plan, and that's it. So that's an argument for not being.
Can somebody draw at some point a stick figure of what you were trying to explain with the 3 payments? That would be really helpful. And
you might be surprised it's not.
And then, pardon?
You might be surprised that it's not, but I can.
But I don't know, Corinne, if you had another question, but I wanted to, I don't know, maybe Mark, your question was what happens if you are signed up to on a DCE and you go outside of network, right? Then who pays that? Was that your question? Who pays for that? And my understanding is that, so the patient goes outside of the network, then CMS does pay for that, for that bill, and then reconciles it, and correct me if I'm wrong, Ed, reconciles it with the DCE that the patient belongs to, and then subtracts that money from the DCE. So there's going to be, my understanding is there's going to be huge incentive, obviously, for the DCE to keep their aligned patients within network, because otherwise at the end of the month or at the end of the year, they're going to end up having to pay a penalty on those patients.
That's exactly right.
Okay, let's, I think it's 20 after, so let's take one more question or one more comment before we wrap up. We have a couple more things I want to say. So Kit Burns, you had your hand up. You have something to say?
Appreciate it. I have just a quick thought on Medicare for All, because that's an issue that will come up, I'm sure. I've looked at this, and I tell people that I'm against Medicare for All, although actually I support Medicare for All totally. But I see the way it's being proposed now, it's so complicated, and these things are set up so complicated that it can't be done. And so I'm suggesting to people, and I'd like people's input, and maybe you can get back to me on this, is to, rather than go for Medicare for All right now, go for Medicare 100%. We simply change it from 80% coverage to 100%. And by doing that, that's a simple thing. You get the support of everybody that's on Medicare. You eliminate the Medicare Advantage programs, which are costly. You eliminate the need for DCEs. So anyway, I just wanted to throw that out, that idea, as if we attack it, that we take everybody that's on Medicare, 63 million people or whoever, we say cover 100% and push for that. Now that's kind of outside the realm of what we're doing, but I wanted to just share that with people. So thank you.
Well, I know I often say that we talk about experiments, CMMI wanting to do experiments. And I often say, well, why don't they experiment with something that we know works, like getting rid of cost sharing, getting rid of, these huge gaps in coverage. So, I think that's it's a good way to frame it, that we're experimenting with all these really complicated ideas that have absolutely no evidence. And we do know what works. And there's a lot of studies that show that doing those exact things would really help people. And Ed and Ann, I don't know if you want to chime in on that.
CMMI could contest anything that they want to, that they think anything they want to, then they have to test it against, can it lower cost without hurting quality, or can it improve quality without increasing cost and at no time cutting the benefits? So they could test, let's try eliminating copays and deductibles and see what that does to quality and cost. Let's put a cap on out-of-pocket expenses and see what that does to cost. They could test the things that we know to be elements of a better system instead of testing the things that we know to be elements of a worse system.
Yeah, sadly, the Build Back Better tried to do that, and unfortunately, there's just a lot of resistance to that. I think it's fine to have Medicare 100% as long as you don't forget that our eye is on the goal of Medicare for All, right? Improved, expanded Medicare for All.
Absolutely.
Right, and I think if we are talking to, and one of the questions that we often get is why does PNHP care about this? If we are speaking with single payer supporters, why should they care about this? This is just like a tiny little thing. But we're really worried that if we don't stop this, there's not going to be a Medicare to expand to Medicare for All. We're going to have something like Medicare Advantage for All, or something that has, commercial insurers running it for profit, and then we've gotten nowhere. So we really need to fight hard and fight quickly to make sure this doesn't take over all of traditional Medicare. And I wanna cut off the questions now just because we're getting close to the end of our time, and I just want to make a few quick announcements. So I put in the chat some links to the slide set, minus my little tips about speaking and answering questions, but the basic slide set that you can download, and you can of course change it as you want. And I'd love to hear your thoughts on it and any questions that you've got. And then I also added a policy primer that we put together. It's 2 pages. It's a little bit wonky, but it helps explain some of the major differences between direct contracting and REACH that we've identified. And basically it's exactly the same, but a little bit or kind of a lot worse. So that might help you understand how to explain this to your audiences. And then finally, tomorrow, like I said in the presentation, we still got a lot up our sleeves. This campaign is still going very strong. And tomorrow we've got another big press hit. We're going to be sending a letter to Secretary Becerra from a group of more than 250 organizations. And I think a lot of you on this call have been very active in getting organizations signed up. So there's, community groups, health groups, senior groups, big groups like Public Citizen down to little, local groups have signed on. And it's a letter to Becerra saying, you can't fool us. We know that ACO REACH is the same as direct contracting, and we want you to end it now. So that's going out tomorrow morning. We're doing some media work around that. I actually just got off the phone with someone from Politico who, wanted to get the full story and find out exactly what are we doing next. We made a big splash with direct contracting. So what are we doing for REACH? So look for that tomorrow. And yeah, that's it. Like I said, we've got a lot of fight left in us, and we've got a lot of things coming down the pipeline. So I see this group as being very pivotal to spreading the word and kind of redoubling our efforts to stop Medicare direct contracting. So again, please reach out to me. You've all got my email. I can put it in the chat again, but please reach out to me with any questions about the slideshow or about speaking, about messaging, and we'll send you more information. We'll send you all the links and more information about all this tomorrow. So with that, I will say thank you and good night and good luck in your presentations.